Thank you, Dr. Vinny. We are really fortunate today to have amongst us Dr. K Mohanty, Professor Dr. K Mohanty. We all know him. He was earlier medical superintendent, HOD Urology, Safdarjang Hospital, and also DGHS, Government Director General Health Services. So just a brief introduction. He done his MBBS from University of Odisha, MS General Surgery from the same university, then MCH Urology from AIMS. Then he has worked for so many years in AIMS, Safdarjang Hospital, HOD, MS, DGHS. He published more than 175 papers in national and international journals. He has been an examiner for MCH and DND Urology. He has undergone professional training at Germany, France and Spain, apart from undertaking health administrative training from IPA. And he is a recipient of WHO Fellowship Award, Indo-Australian Fellowship Award, Indian National Science Academy Fellowship Award. He was chairman of NEET 2013. NEET, we all know, is National Eligibility and Entrance Test for Medical Undergraduates and Postgraduates. He is a life member of many national and international urological organizations. He has delivered 7 oration lectures and has received many awards like IMA Distinguished Service Awards, Teacher of Excellence Award by National Board of Examination. Now I present to you Dr. N. K. Mohanty. He will speak on what is new in the management of carcinoma prostate. Professor Mohanty, sir. Please welcome Dr. Professor Mohanty.
Good evening, friends, and all of us know each other. Many of you are known to me, and I am known to you. I have not come here to teach you. I have come here to discuss with you, for which you will gain and I will also gain from it. Your experience is vast as compared to me. And if you are in this practice, I am really proud. For one thing is by 9:30 the house is full. That shows your enthusiasm to have a collective CME, whichever subject it is. Teaching is my passion. And you have been one of my students, and when I finished my internship, Cecil joined me and Cecil joined me. Now, what I'm going to talk to you today is a lot of things have been spoken about cancer prostate problem in his life. Now, see, I would like to give a little stress on the epidemiology, because that will only give us the importance of this subject. Now, it is the second most common cancer in elderly males and the 6th cause of cancer death worldwide. This is the statistics, latest 2018. After the skin cancer, it is the next common cancer which affects elderly male. It accounts for 33% of all newly diagnosed cancers among elderly males in the US. Fortunately, we belong to the Orient, so the incidence is less as compared to the African Americans, the Hispanics, but taking into consideration our vast population of 1.35 billion, out of which about 38 to 40% constitute males above the age of 60 years of age. So from that you can imagine what will be our total incidence, though we don't suffer as commonly as the African Americans or the Hispanics. One thing is found that the incidence of this malignancy is more among the people who stay in the urban areas than on the rural areas. Now, one of the studies which has been done, it is population-based control randomized study done by the ICME 2010 and 11, when I was a part of it, that in the district at Kamrup, that is in Assam, the incidence of this malignancy is as high as 11.6%, as compared to BIOPSY, which is in Gujarat, 0.3%. So this only shows the vast difference in the incident rate in our country, a huge country like ours. The incident rate is highest among the Australians and the New Zealanders, about 104 per every 100,000 population, as compared to 1 to 9 in the Asians, and we belong to this group. Now, WHO has calculated that by 2030, the incidence of this malignancy in the world will cross more than 1.7 million new cases per year, and about 49,000 will be the deaths annually. So this only shows the magnitude of this malady which is coming up. In India, one of the statistics has shown that, this is again ICMR data, that 2015 we had about 39,200, and by 2020 we will come up to 51,000. So all these rates are showing there is increased trend in this incidence. The most surprising is 1 in every 6 elderly Americans will suffer from this disease in their lifetime. 16.7%. So the Americans are really worried, as it may be a dormant cancer in them, but they will definitely harbor a cancer focus in their prostate. And about between the age of 70 to 80 years, the incidence is very high among cancer prostate. Now there are certain risk factors which has come up. And the first risk factor, now it is a familial disease. Earlier we thought that this disease, if it affects the family, it will not be transmitted to the offspring. It does so. And if a father is suffering from cancer prostate or is died of cancer prostate, his sons will have 50% chances of developing cancer prostate in their lifetime. And this cancer prostate, which is a familial history, affects their offspring at a much younger age as compared to the others. Usually this is a disease after 60 years of age. But if it is a family history, it may occur at the age of 52, 53. And these cancers are very aggressive as compared to others. Now, there is some talk going on the diet. It has been found, and it is proved beyond doubt, that those who take rich cholesterol diet, particularly red meat, which the Americans they take a lot, fatty foods, and a lot of dairy products, which we take a lot in India, particularly in North India with paneer, cheese, yogurt and milk, have a higher chance or are vulnerable to develop cancer prostate. But those who take diet which is rich in antioxidants like lycopene, soybean, which has got flavonoid, fruits, have a low risk of developing cancer prostate. So this is the diet which has come up recently. It is a disease governed by the genetics. So it's a genetically oriented disease now. The RNA cell gene in the body is a tumor suppressor gene which regulates the proliferation or apoptosis of the cells. Now, if this RNA cell gene expression shows any kind of mutation, deleterious, then the expression will become high. And once this becomes high, then there is every chance the patient will develop cancer prostate. So this is the genetic coding, and nowadays a lot of your markers are based upon this of gene. Person having a high BMI and a high bone mass has more risk to develop cancer prostate. So these are these few hypotheses, few data which have come up recently, so one has to be careful. Now, after saying so, what we can do? Up till now, we don't have a tumor marker which can clearly diagnose that this gentleman is suffering from cancer prostate. PSA, which is being used for the last 30 years, is not a tumor marker for diagnosis of cancer prostate. It is a myth. Yes, but it is used to see the progression of the treatment, whether the treatment which you are given is effective or not. As all of you know, that any cancer in the body, if it is detected at an early stage, sent to the respective faculties of the that subject, diagnosed very early, radical surgeries can be done, and the survival rate is high. Similarly, it happens in cancer prostate. Now, if we detect this cancer prostate at a very early stage, most probably we can give them a 15-year survival rate. Because by and large, cancer prostate is an indolent ulcer. It goes very slowly, and it is very easily clinically detected because it is in the rectum and we can do a rectal examination, unlike other things. Nowadays, the PCA3, prostate cancer antigen 3, is one of the biomarkers which can detect cancer prostate at a very early stage. And this is done from the urine, not from the blood. Because all cancer cells, irrespective whether it is a hepatic malignancy or GI malignancy or breast cancer, they set cells into the blood and also to the urine and to the other exfoliants. So these circulating tumor cells are picked up from the urine and in that mitochondria RNA. And if the cells from the urine of a gentleman has mitochondria RNA in a high level, this is or overexpression of this RNA, then definitely this gentleman is suffering from cancer prostate. And mind it, this is done at a much earlier stage before PSA becomes 4. At a much earlier stage, when the PSA is 0.7, 0.8, 0.1, you will find PCA3 in the urine. Therefore, we can detect the prostate before even it has gone out of the organ.
So this is called PSA3.
This is PCA3. PCA3, not PSA. I'm sorry if I told you. Now, this is more specific than PSA, and its presence in the urine detects the cancer prostate. That this gentleman is definitely having cancer prostate. Now, the sensitivity of this PCA3 is about 92 to 93%, and specificity is much higher as compared to PSA, which is about 65 to 70%. Therefore, you can realize that this should be the ideal marker to detect cancer prostate at early stage. Fortunately, the FDA has given approval to this. It has been commercially marketed in Europe and US, and I'm sure very soon DCGI will give a permission to bring this into our country so that we can diagnose our patients at early stage. The other one is again the genetic markers. Nowadays you must have seen that a lot of genetic markers are used as biomarkers for any kind of malignancy. TMPRSS2 ERG abnormal cells. This is again a biomarker from the circulating tumor cells in the urine. Its presence in the urine indicates very early cancer prostate, and this distinguishes whether you have a cancer prostate or a BPH. You must have seen many times people will come, sir, my PSA is 7. I am having cancer prostate. You send it to the urologist, they do biopsies, and they find there is nothing there. This kind of controversy will go once you have these kind of genetic markers in the market. The other markers are the PHI score, 4K score. I would like to emphasize another marker is K167. This is again a marker which is being now used aggressively to show that the cancer you have, it doesn't say that you have cancer prostate, but if you have a cancer prostate and the expression of K167 expression is very high, that will tell that this kind of prostate cancer is very aggressive. So we have to take a very quick decision to treat these patients rather than waiting and watching. So K167 is another marker which is coming up to show the aggressiveness of the...
From urine or from blood?
This is from the blood. Now, this is a talk from the urologist, ISO-PSA. When you had PSA for the last 30 years, how can you forget that this is not a good marker? See, what happens exactly, when you detect a PSA in the blood, we detect the concentration of prostate-specific antigen in your serum, nothing else. ISO-PSA, when you detect it, it shows the molecular changes in the PSA. So there's a difference. Here, PSA only gives a concentration, which we have read it now. And here we are telling what are the molecular changes in the same PSA, which may be different from A, B, and C. This is superior to PSA because it distinguishes between BPH and cancer prostate. As I told you, many people will come 7 PSA, 8 PSA, cell metal cancer. So you do everything, you find nothing. You tell, wait and watch. He is not happy with you. He will go to another gentleman. This PSA will tell, if this is there, then you are not having BPH. You are having only cancer prostate. Therefore, it is a very significant marker which is coming out very soon to us. It not only differentiates between cancer prostate and BPH, it also identifies the high-grade PSA, depending upon its expression in the serum. Therefore, unnecessary trust-guided biopsy will be reduced drastically if your ISO-PSA is raised as compared to PSA we have it now. Anyone who has a PSA raised now has to undergo a trust-guided biopsy. And the gentleman who undergoes a trust-guided biopsy, it is only he can explain how painful it is. It is not the doctor or the urologist. So we can unnecessarily stop this kind of biopsy if you have the ISO-PSA, which is also going to help us. If the ISO-PSA is raised, there is no need for a biopsy. It is going to be that accurate. A lot of things have been talked about liquid biopsy. What is liquid biopsy? The cancer cells, they shed cells and genetic materials into the blood also. And the technology is to be able to isolate the tumor cells and the DNA from the normal cells and the DNA in the blood, and then read and interpret what it means is termed as liquid biopsy. So nowadays, this is going to replace a solid biopsy. Why? Before that, it is a non-invasive procedure. As you take a fasting blood sugar level, you can go on taking it from the blood organism. It can be repeated. This gives the heterogeneity score of the tumor, how heterogeneous it is. And it also guides the best therapy response you can give to the patient if the score is high. What happens? You must have seen a patient comes to us, we find that no, he is 75 years of age, he is not going to undertake a radical prostate surgery, let him put him on hormone therapy. Now after 16 to 17 months of hormone therapy, you see his PSA is going up. He is throwing a met somewhere in the hole. Why it happens? Because primary tumor in the prostate and the tumor cells in the areas of METs are different. The primary cell in the prostate, which can respond to the hormone initially, the secondaries do not respond to it. And because they change their mutation, the genetic mutation of these same tumor cells changes, and therefore the response to one treatment differs and you have put into the secondary. And this can be detected by a liquid biopsy. So the mutation from the primary site, say for example the prostate, shows changes at the metastatic sites. And this also gives a heterogeneity. How heterogeneous it is, how designing the cells are, how fast they are dividing, what is the nuclear pattern in these cells, what is the nucleoli in these cells, right? What is the percentage of the nucleus with the cytoplasm in the cells. So all these things will guide us for the response of the treatment. Hormone therapy which fails if the heterogeneity score is high, but it doesn't fail in chemotherapy. Therefore, we cannot blindly give, ये नहीं हो रहा तो इसको लगा दो, ये नहीं हो रहा तो उसको लगा दो. These things are now to be stopped because you cannot make a guinea pig of a test. You have to give them the right treatment, the evidence-based treatment nowadays. Now, this is as far as the markers are concerned. Now, let us see if there is any new thing happening in the imaging, because we depend a lot on the imaging. Radiology, urologists, they depend a lot on this. A lot of things has come up like color Doppler ultrasound, elastography ultrasound, multiparametric MRI, enhanced to detect all this malignancy. But the one thing which is helping us nowadays is enhanced MRI, which can differentiate whether the lymph nodes which has been enlarged are full of metastatic cell or it is a reactive lymph node enlargement. And this is done by the enhanced MRI. I think so we have not got this MRI facility in our country, but I'm sure we are everywhere. Our medical system is very fast and we're sure that we'll get this system very soon in India. First we do a standard MRI, then the radiologist will inject small magnetic particles, then repeat the MRI after injecting that in the next day. Then the difference between the two scans points out the lymph nodes which are enlarged are having metastatic cells or non-metastatic cells. So this is a very good, so it can happen in any malignancy. It can help us.
That will also say that will also show the same thing.
Which one?
PET scan.
CAT never tells you whether this lymph node has got a metastatic cells or not. Until once you do a CAT guided aspiration of the metastatic of the lymph nodes. You see a cytology. CAT will only show the enlargement of the lymph nodes. Can CAT give histopathological evidence that this lymph node has cancer metastasis? I don't know.
He's talking of PET CT.
PET CT.
I'm coming to that. PET CT से और भी ऊपर आ गया for cancer prostate. Is the PSMA PET scan. This is one of the best. Yes, because the radionuclide which is injected in PET CT are magnified in those areas, not only in the lymph nodes, also in the bones, also in other sites, in the liver or the other sites. Now we are urologists are not doing MRI for prostate cancer. We are also not going for a CAT scan for prostate cancer. We are not doing a bone scan for prostate cancer. What we are doing nowadays is a PSMA prostate cancer. Prostate specific membranous antigen PET scan, which is available in our country and widely available in Delhi, gives us not only the anatomical configuration of the malignancy in the prostate, whether the capsule is breached, whether it has gone to the seminal vesicle, whether it has gone to the bladder neck, to the surrounding tissue. It also gives rise to the lymph nodes. I do agree with you, gentlemen, that yes, it does help. And second thing, whether the bones are involved or not. So if you do only one PSMA PET scan, then I think so you can avoid all this CAT scan, MRI, and bone scans. Now, which is coming up, which can yield the result of the biopsy. So you must have heard that the urologist has taken, he has done a 12-core prostate biopsy. एक आदमी का 12 जगह 5 check करना in such a small gland is really good. कभी-कभी हम maturation biopsy करते हैं, कभी-कभी हम 18-core biopsy करते हैं because we are not getting the good yield. Now this fusion prostate biopsy has stopped all these things. So what they do now, radiologist along with the urologist, now they first take a truss ultrasonography of the prostate and they fuse this image on an MRI. And from that they can superimpose this ultrasound image onto the MRI image, and there we can find out exactly which are the hypoechoic areas in the prostate and which are not abscesses, which are not cysts in the prostate, which are not infarct area of the prostate, but malignant cells. Because all these things will give a hypoechoic. So simple MRI CT cannot differentiate that. And if you see, out of these 7 hypoechoic areas, 2 are in favor of prostate cancer, do a biopsy for those 2 rather than doing for 16-core biopsy. So this fusion biopsy is available in it, and I think so Vedanta has also this fusion biopsy facility. But nevertheless, slowly all the other places we can have this. So this is a great boon to yield. With only single biopsy you can treat the area. So radiological imaging, advanced tumor markers with history that this is a genetically progressed disease, we have to come to know treatment of it. Now, this is a disease which occurs only in elderly people, until unless there is a family history. Therefore, our normal average age expectancy of a male from 48 years at independence has now come to 69 years in 2018. So we expect that a lot of elderly males will be present in the society. And age is one of the biggest risk factors for development of cancer. The more the elderly people will do, there will be changes in the prostate cells. Therefore, we have to manage them, detect them early, and institute the best treatment which you can do. Surgery, of course, stands the best treatment modality subject the tumor is organ confined or it has just reached the capsule. But if it has gone beyond the capsule, then I don't think so we can do a good surgery leaving a tumor margin-free area. Surgery, radical prostatectomy is the best. Whether it is done open earlier, followed by laparoscopic and now robotic, the schedule, steps, everything remains the same. What happens in this surgery? The morbidity is high. You have to always counsel the patient, you will have impotency. In a country like us, elderly male, they may not care for impotency, but in foreign countries they do care a lot for impotency. Incontinence of urine. This, even if whatever technology you do, we do a lot of radical prostate surgeries, but definitely no surgeon in the world can say that I'll see that you are not going to use a diaper for the next 6 months. He has to use a diaper for the next 6 months. Maybe less amount or small amount, but the incontinence stays. Stricture of the urethra is another thing when you do an anastomosis. And this kind of surgery is not free from mortality also. It may be less than 0.2%, but mortality is still there because it's a surgical procedure. By doing such a radical surgery of 4.5 to 5 hours, spending so much of money for a robotic surgery, it does not give immunity to the patient, then there will be no recurrence. After 2.5 to 3 years, your PSA, which is 0.2 nanogram at the time of surgery, starts rising. So you are not immune that you are not going to have from prostate cancer. Though we do radical prostate, cells must have been thrown into the lymph nodes into the bladder. So some elements will take place, and against the cost. I'm giving importance to that because why other modalities are not coming up. Now, the next is, do you have any role of focal therapy for cancer prostate? Now, this is a bridge between active surveillance and aggressive treatment modalities for localized prostate cancer with low volume, where surgery is the treatment of choice. Now, what is the rationale? Why you want to have a focal therapy? Many patients who come to us who are low risk, whose PSA is less than 10, whose glycine is 6, it is an organ confined, and is in the middle age or elderly group, we say, okay, you are in low risk patient, we don't require surgery for you. Let's put you on active surveillance. You come to me every 2 to 3 months, see your total PSA velocity, whatever you want to do, because you don't have a PCA3 now, and I'll see whether it is progressing or not. Now, 33% of such kind of patients who are under active surveillance develop cancer prostate. And this, they are already cancer prostate, low risk, they become high risk during the surveillance period. So by the time, within 3 months, you have finished the bus, at least you could have done a radical surgery here. Now you can't do a radical surgery after 3 months because 33% of them has become very aggressive and you have to don't know what I will do now. So the chances of survival for this gentleman has been lost. At least 1/3 of them have lost it. Again, the reverse. So under treatment. 49% of cancer prostate who undergo active surgery, no, you come, I'm going to do radical surgery. You are a high risk patient. Histopathology has shown, no, they were low risk. So you have overtreated 49%. So to bridge the gap between an under treatment and an over treatment, let's put a focal therapy. And what is that? We have to select the patients who have comorbid factors, very old, unable to stand radical surgery, very obese, you won't be able to reach the pelvis easily, patient has an unstable cardiac condition or respiratory condition, patients with IBS or patients who would not prefer to undergo surgery. These are the patients who can undergo focal therapy. The patient also are reluctant to undergo surgery. Many of them really say, I don't want surgery. Why should I go surgery? You show me other modalities. The other modalities are radiotherapy for us. Now what is the advantage of the focal therapy? Why I am focusing on this? This will be within a few months or a year, this will be the top or the treatment of cancer prostate. It is an outpatient procedure, a daycare procedure. You need not admit for 4 days in the patient, which 1 day is in ICU after radical surgery. It can be done under nerve block and local anesthesia. Of course, initially they are giving spinal, but now they have proved by giving a good local nerve block by anesthesis, it can be done. Accurately target localization by 3D mapping that I told you by MRI. Side effects are less. There is no impotency, there is no incontinence, there is no structural problem. It can be repeated. Because cancer prostate is a multifocal disease. If it is on the left lateral lobe, on the apical, tomorrow it means the right lower lobe on the right side. So if you have hit and done the focal therapy for the right side, after 6 months you see he has got on the left, then we can also target it. Again with the focal therapy, and it is cost effective. Aim of this, first of all, to reduce the tumor burden, assuring good cancer control, avoid radical surgery complication, maintain a good quality of life, and we preserve the organ, avoid undertaking or over-treatment of low risk or localized medicine. So all these things are taken care by the local therapy. The only disadvantage is that it may be repeated, and that will definitely add to the cost. What are the local therapy available with us? HIFU is number one, and this is improved internationally. Many of the European centers, they don't go for radical surgery nowadays. Americans still do the radical surgery, but many of the European centers, Australians, they go for focal therapy, and HIFU is the best focal therapy available. This is a high intensity focused ultrasound. We use ultrasound at a very high intensity, and we cause tumor necrosis on that area. The second is cryotherapy. By freezing the prostate to -80 degrees, causing cryo ice balls inside the prostate. The third is a vascular targeted photodynamic therapy. Fourth is nanoknife surgery, which has also come out. Laser ablation, focal brachytherapy. Radiotherapists nowadays they don't give a total brachytherapy. They are also trying to minimize. So they give a focal brachytherapy. Then, last but not the least, is the radio frequency ablation. Use a radio frequency energy. And on the horizon, looking to come in to this armamentarium of urologists and also to the hepatologists is aqua ablation, where we're using water at a very high jet to cut. The advantage is that if you freeze that water to low temperature, the bleeding is not there. Number one. And number two, we are using water which is cost effective. And it can cut through the tumor. Liver malignancy is another thing. Ovarian malignancy that we get for this. So this is aqua ablation, but here we approved nahi kiya hai. It's still on the trial basis. Now I want to concentrate a little on HIFU because this is now the best modality among all the five. It got an FDA approval in 1998 or 2000. It is used for localized cancer prostate. Here what happens in HIFU, the temperature is raised up to 80 to 100 degrees Fahrenheit. It causes tissue coagulative necrosis in the areas where you are going to pinpoint it. Can be done under local anesthesia. Treatment time is only for 3 seconds. And cooling time is for 6 seconds. Because it is such a high temperature of the ultrasound, you cannot prolong it. One of the studies, they have already come up with 5-year studies. One of the 5-year studies from the European Center has seen disease-free survival is 66%. Means a patient, 66% of the patient having localized cancer prostate undergoing HIFU are not having any tumor in the prostate. It's very high incidence. And it can be repeated if you find a second focus. Cryotherapy is done in some centers, and I don't want to study 10-15.
Yeah.
So the dinner is waiting for all of you. So it is done in some places. We use cryo for renal cell carcinoma rather than for prostate. Vascular targeted therapy, nanolife surgery. I'm not going to come. Brachy, collaboration. Then, will you allow me to go for a little more?
Yes.
Now, what is happening in the hormone therapy? Now, we have been using LHRH agonist. Now they have come up with GnRH agonist. Abiraterone, all of you must be using it, but it's slowly being withdrawn. Enzalutamide is practically withdrawn from the market because it is causing seizure. Now coming to this Degarelix, which is being very commonly used, it was approved in FDA by 2008. The advantage of this, as compared to LHRH agonist, is that it also reduces the FSH level. the follicular stimulating hormone and luteinizing hormone from the pituitary is reduced by GnRH antagonist, unlike in case of the agonist. Now, FSH is reduction. FSH is an inflammatory hormone. Therefore, these patients who are suffering, having a cardiac problem, thromboembolic phenomena, cardiac problems, you cannot give them a hormone therapy with LH-RH agonist. But here we can use them. And this has shown to improve the cardiac status because of FSH reduction. This is the advantage. The dose is 240 milligram to start with, loading dose 80 milligram every monthly for 12 months. Abiraterone, all of you know. And the side effect is myopathy, which is coming up. Many of our patients come with severe weakness, backache after using abiraterone. Enzalutamide, the greatest side effect of this is seizure, though it is rare, and visual hallucination has been also seen. Now, targeted therapy, I'm going to jump. I'm just going to the last slide, chemotherapy, immunotherapy. This is also coming up in all malignancies. Vaccine, Provence, all have been rejected in urology nowadays. Now, what is coming up in all this immunotherapy, not only in urology, is the checkpoint inhibitors. Now, the immune system of the body has the ability to keep itself from attacking the normal cells by checkpoints, molecules. And the immune cells that need to be turned off and on, whether it is a cancer cell, so that immune system will improve, or it is a non-cancer cells, the immune system will fall down. Now, cancer cells are used sometimes to check these immune points. They tell that though they are cancer cells, they stop the immune system of the body. The cancer cells are notorious in the body. Now, to avoid this, you have a checkpoint inhibitors. Only it will act on the immune system. And the common checkpoint inhibitors for cancer prostate are these three drugs which has come up. They are all monoclonal antibodies. And these checkpoint inhibitors block and shut down the signals of the immune cells so that they revive and kill the cancer cells. This is being used, and few of these drugs are available in our country. Medical oncologists are the best person to guide us on that. I think so. He has already lived his 69 years of lifespan. And if I do a heroic radical surgery and come out of the room and say, oh, I did 80 साल आदमी का radical surgery, after 2 to 3 hours, my ancestor will not get a cardiac arrest. What can I do for that? Is it reasonable for me to allow this gentleman who has a silent cardiac problem to be accelerated by this surgery? So I'll put them on other modalities. But internationally, you can do
Up to what age do you become a radical?
There is my 70 cut up. I don't want to do anything more than 70. Because unnecessary taking a risk. And you may have done the very good, but you don't know what will happen to you. There are a lot of problems, anesthesia problems. Surgery itself is a trauma to the body. And he may be having a silent MI, which has been exaggerated after that. He is an ICU or a ventilator. Is it worth doing it? We have other modalities which can prolong his life also. So what do you think?
Focal therapy, you discussed about focal therapy. It is not against the basic principle of curative oncosurgery that we are not removing that, we are not doing the wide excision or whatever is the basic principle. We are just destroying the tumor cells there.
See, I tell you, radical prostatectomy we should do. I wrote one line. This does not give you an immunity for developing a recurrence. The last line. So even if you do a radical prostatectomy, you are not going to say that patient has cured cancer. No doctor can do it. So why do you tell a lie? Second thing, this will recur. If it recurs, why not go for a much easier, simpler therapy, like focal therapy. Repeat the therapy and Vinith will come up with me. There is one of my things which I have told I'll join you. If you bring IQ and we are getting IQ in our sector. That is we get highlight.
So I'll tell you, now there are two schools of thought. Again, to understand the first question that you mentioned, there are a lot of countries across the world that will not do a PSA test after 75. So when you say that a cancer is diagnosed at 80, it means he's undergone a biopsy at 80, which is actually not recommended. Beyond 75, even PSA testing becomes very, very infrequent and irrelevant. So actually diagnosing it at 80 becomes very tricky. Focal therapy has now a huge amount of cancer prostate treatment is based on 3+3 reason, which is cancer prostate, which is early prostate cancer. So cancer prostate has been divided into 3 different zones, which is categories, which is early, intermediate, and late, and advanced. And when you are dealing with early prostate cancer, that's where the confusion arises. And here you can use surveillance as a means of, and in fact here a lot of centers will prefer to use surveillance rather than radical treatment because of its side effects as a mode of therapy. It is here that focal therapy makes a lot of sense, and a lot of centers across the world will prefer to then, instead of focal therapy, instead of surveillance, use focal therapy, which has few side effects as an alternative form of treatment. So we must segregate where we are using what. And if we understand that and where we can use it, possibly use it, then it actually makes perfect sense.
Last thing from my side, you have done a lot of research on writing on lycopene. So is it really worthwhile to take lycopene to prevent prostate cancer, and how much of lycopene? You have done a lot of research.
Lycopene does not prevent prostate cancer. It's an antioxidant, mostly from the tomatoes, and that will be from the skin and the other portions, not from the pulp. And these tomatoes we don't grow in India, it is mostly in the Mediterranean country. It can, suppose if you have a hybrid pin, which is a potential cancer prostate. Later on it can develop into cancer prostate. If you give lycopene to these patients who are diagnosed pathologically as hybrid pins, then you may prolong its conversion into local cancer. Telling that lycopene prevents cancer prostate is a wrong concept. So no one should have that concept. Second thing, these are all antioxidants and they do reduce the PSA level.
I have one question with Dr. Mohanty. It was a new thing for me that we should send patients, because we were sending patients to PSA. It's a good information I have got through you that we should send patients for PCa. Same way I want to know what food we should recommend, as you said, like the tomato. Tomato can't be only thing. Please elaborate that.
See the pink grapes.
Pink grapes.
No, I can't. Pink grapes.
Pink grapes. Pink grapes.
Pink grape.
Pink grapes. What is pink guava? Pink guava.
Okay.
These are the 4 or 5 fruits which are very rich on antioxidants and also soya bean is another thing we can make, because it has got lavendol in it, which is again a good antioxidant. So these are the 5 or 6 fruits which
Right.
you can use.
I will hand over to
Or
Dr.
in these ideas.
Less chance of malignancy. ISO-PSA you told about that. Na?
ISO-PSA, if it is raised, you have a more chance of
More chance.
because it measures your mitochondrial RNA as compared to only a silk concentration.
And how about the choline fat? Choline fats. Choline fats. C11.
Choline fats can come again with the patterns. It is quite significant. But when you I have only touched about the prostate cancer. If you have prostate specific molecular antigen, that is a PSA and a PET scan, it is not specific for prostate cancer. But is very good for other malignancies.
Dr. Tulsi.
Like finasteride and dutasteride, do they reduce the risk of CA prostate?
Definitely. Because testosterone is actually the feeding for the progression of the prostate. Actually what happens, the philosophy of all this hormone therapy of prostate cancer, it does not treat prostate cancer. What a hormone therapy does, it prevents the prostate to grow. And for prostate to grow, you require testosterone. And that testosterone, when it is converted into dihydrotestosterone inside the prostatic cell, they combine with the nucleus of the prostatic cells, and the prostatic cells survive. And the more the prostatic cells survive, more is the chance of becoming malignancy. So what we are going to do, cut it off. Army mein kya hota hai? If the enemy is there in the fort, they cannot reach, so they cut off their supply line, the food and the water and electricity. Exactly the same thing we do for a hormone therapy. So we don't allow them to grow. It does not treat cancer prostate. It stops the growth of the prostatic normal cell.
I was asking about its prevention. Would it prevent CA prostate?
No, not at all. Not at all.
It would not prevent CA prostate.
Not at all.
Okay. So you talked about the PCA3. Should it be done after a DRE?
Why not? You don't know. See, PCA3, usually we do a DRE. Try to do a little prostatic massage. Exfoliation of the cells comes into the urine and then you collect it. So the yield will be far better than normally taking urine from for a PCA.
So you said that no longer biopsy is needed because if the ISO PSA is raised, there is no need for a biopsy.
It is now coming up as specific as 98 to 99% as a marker.
Right, sir. So what about the vaccine, the Trojan and the Prostate?
It is absolute as far as urology is concerned for cancer prostate. So we are now coming up with checkpoint inhibitors.
Okay. So what about this? Supposing if you have a localized CA prostate, so 5-year survival would be about 100%?
Not necessarily.
Not necessarily. So what would be the 5-year survival? If you have a localized prostate,
It depends upon many factors.
Yes.
Number one is initial tumor marker level. Number two is Gleason score. Number three is lymphovascular invasion in the biopsy and the neuroendocrine cells if there is any. All these four parameters judge whether it is a low grade, it is intermediate, or it is a high grade. Now, which tumor you are taking on what grade depends upon the prognosis. Suppose you have a very low grade tumor. Definitely, your 5-year prognosis is more than 80% as compared to a high grade, which will be 60%.
So my last question. MFS, metastatic free survival, has come a big way, published recently in NAGM, June 2018. So is it because the survival of CA prostate is probably more? The MFS, metastatic free survival.
Of CA prostate.
Yes.
Which article is this?
So this is published in NAGM, June 2018. It's a new word, new word coined. The MFS. So just what is that?
I have not read this article, so I won't be able to comment on that.
I am divided by 4. So, talking to the latest single dose radiation therapy, there is a WhatsApp going on about Arjun Rampal. His mother had breast CA and treated by some Portuguese hospital with single dose radiation therapy. It is also good for metastatic prostate cancer. Any idea about that? Single dose radiation. They call it single dose radiation therapy. It is a very targeted therapy.
Oh. IMRT? Is it an IMRT? See, first of all, you should excuse me, I'm a neurosurgeon, not a radiotherapist. But whatever little knowledge I have about radiotherapy, I think so. Focal brachytherapy is taking up much more priority than your even IMRT.
Coming to your specialty, any role of polyectomy?
Yes, we do.
Because say oophorectomy was very popular.
I agree with you. In a country like India, if I'm going to give a hormone therapy to a patient who doesn't have 1 square meal a day, am I justified? no, I'm not justified as a surgeon. I'll remove his testes rather than putting him on regardless. He cannot have a square meal in a day, and I'm going to ask him for a thing. It is, I never treat anyone, my treatment is never a formal treatment therapy. So, I have to do treatment for that man. He also requires triple treatment. So, let me do a bilateral.
Right, sir.
It has a role.
Absolutely right, sir. Liquid biopsy, is it only for CA prostate or for every prostate?
All malignancies.
For metastasis and for the
All malignancies.
So, is ISO-PSA equivalent to, as we say, CPK-MP versus CPK or drop fees, tissue-specific versus drop fee? I mean, it's a isomer of prostate?
It is, yes. See, ISO-PSA is a PSA where you analyze the mitochondrial RNA rather than the concentration of the PSA in the serum. So, this is more specific and more genetic oriented than the normal PSA.
My last question to Mark, my present sir, is any value of PSA which rules out CA prostate?
Yeah, PSA never rules out CA prostate.
So there is much of bodybuilding centers all over India.
Bodybuilding.
Then those who are coming for bodybuilding, they are taking testosterone regularly. What the incidence or is there likelihood of developing and how?
See, I cannot, because these bodybuilders are youngsters. So their cells are not attuned to become malignant at this age. But definitely they get hematuria. I have treated many of these bodybuilders who come with hematuria. Everything has been ruled out. I said stop this steroid, don't go to the gym, and then hematuria starts. As far as malignancy is concerned, I have no idea.
What is used is a different thing altogether. What you use as a rational dose is something else.
For bodybuilding, testosterone is not recommended, cannot be recommended. It is not medically recommended. Nobody can recommend. But it is not medically recommended. It's not cancer prostate. It should not be used. There are so many side effects of unnecessary use of testosterone.
I'll tell you one thing. I'll just clarify your doubt. Testosterone given as a replacement therapy for low testosterone, particularly in androgens men. If you have a cancer focus in the prostate, it is going to aggravate it. But if you don't have a cancer focus in the prostate, whatever testosterone you give, it will not go to aggravate. So that's why we do a PSC sometimes or even a biopsy. Testosterone will only aggravate if there is an existing cancer focus in the prostate.
I have a bit of a comment. Sir has tried really in a very short time to touch upon such an exhaustive subject, which is really exhaustive even for a practicing urologist. And I think the confusion in the audience I can see because it's so difficult to comprehend. Basically, what is the advancement in CA prostate is that if you see that CA prostate is in two, early and metastatic oblique advanced. There is hardly any worthwhile treatment advancement with early prostate cancer. Whatever sir tried to highlight from my understanding is basically in the very select group of people. You can't apply to all groups. Early prostate cancer means radical prostatectomy, oblique radiotherapy as per the choice. In the group of that age group, you can't apply to a 75-80-year-old man. No, not at all. It's only a very small group that you can apply those HIFU or cryotherapy or something. So in the early cancer group, the maximum advancement has been done in the investigation, the diagnosis, the accuracy and the frequency where you can pick up the cancer prostate. But it is in the advanced or metastatic group where most exciting work has been done in the treatment aspect, where you can advance the treatment. Now that also comes with a rider. All this work has been done in the West, where survival beyond even 2 months, up to 2 months, is a huge thing. So if you go into the details of the treatment advancement, where you see abiraterone or docetaxel or all the newer immunotherapy, you will be surprised to know the only advantage of life is up to the level of 2 months, 2.5 months. So is it, when we are discussing over here, is it applicable to a country of our time where the cancer prostate is a little different? Not only that, can we afford that treatment? Is it applicable to everybody? Is it worthwhile? So we have to see in that way. We can't blindly follow whatever the West is doing. Yes, you and I may be able to afford Abiraterone plus prednisolone plus something else plus HIFU, but it will not be applicable to most of the people in this country suffering from advanced prostate cancer. And that's an important aspect which we should remember.
Now, Abiraterone has already come up, which is in the horizon, which is yet to be launched in India. India has given approval only 2 months back. All these are evidence-based. Whether you take a latitude thing or any other study. And the question is, you cannot ignore this because we don't have any evidence in our country. But that doesn't deter that you cannot give the same treatment or advantage to people who are affordable. A question is asked to me whether organ treatment has to be done or not. I said, yes, we do organ treatment nowadays also. We cannot even deny a patient who cannot afford any drugs, organ treatment has to be done. So you have to do the balance and the check. Affordability is one of our priority for our patients. But nevertheless, don't compromise and say, no, tomorrow we will not
We should offer the...
Sir, is there any correlation between a patient if he comes to us at the age of 45, 50 with erectile dysfunction and later on he can be a patient of prostate cancer?
I don't follow you. Can you repeat it?
Sir, if a patient comes to us with the condition of erectile dysfunction at the age of 40 or 50 and later on he becomes a patient of prostate cancer, is there any correlation?
See, sexual activity has shown in some very small area to increase malignancy, whereas it has been again in another study, vasectomy does not allow prostate cancer to develop. There is a lot of controversy in this group. Now one has to look into it in detail if there is some specific on this patient, because I have not seen any patient who has erectile dysfunction having cancer prostate proved at 45 years of age. But it is time to take. There are no evidence till now.
Sir, in hemospermia, is there any chance of malignancy?
So this is vaccine was a one
Hemospermia. Hemospermia.
Hemospermia.
Yeah.
Chances of several vesical malignancy is there. Not prostate malignancy. See, when you get hemospermia, it is mostly coming from above. Right. So we always do a test to rule out whether there is inflammation in the central vesicle, whether there is malignancy in the central vesicles or diabetes. So these are the very three common things, but not prostate cancer. But yes, prostate cancer, the breeding in prostate cancer is much less as compared to benign prostate cancer. So even if you don't need.
But can the human papilloma virus vaccine any role to play to prevent cancer?
Papilloma virus vaccine.
Papilloma virus vaccine was first thought to cause malignancy, and particularly the C inclusion bodies of the virus. Right? But up till now, I don't think so any evidence is there. Human papilloma virus are involved. Up till now, there is no evidence.
Sir, excessive ejaculation, does it protect prostate? Excessive ejaculation.
Many
Friends, I think this was one of the best lectures on CME Programme. I am a member of Urology Society also, sir was there in many meetings earlier also. It was very educative. He, I think, covered all the aspects of latest in diagnostics as well as management in CME Prostate. We are very fortunate to have Dr. Mohanty amongst us, and we are thankful to Dr. Chauhan who brought.
I would
दो मिनट ले लो यार